This is not a medical presentation in the strictest sense of the word. I want to be very clear about that from the start. There are no drug names here, no dosing tables, no DSM criteria. What I want to talk to you about is something far more important and far more durable than any of those things. I want to talk about how to think. Specifically, I want to offer you a model of thinking, rational, logical, critical, that you can apply to any clinical situation you will ever face. But I should tell you up front, this model is not limited to medicine. You can use it to buy a house, to choose a partner, to decide whether to change careers, to raise a child. It is a universal framework for navigating complexity. We are simply going to apply it here to the particular complexity of psychiatric practice. So let us begin with the single most important principle in all of clinical medicine, and it is not what you think it is. It is not diagnosis, it is not evidence-based, not treatment. It is not evidence-based practice. It is this. First, do no harm. Primum non nocere. Before you do anything, before you prescribe, before you refer, before you open your mouth, ask yourself whether what you are about to do has a reasonable chance of making things better without making things worse. This is not a platitude. This is the North Star of everything that follows. Once you have committed to that principle, the work begins, and the work is this: to eradicate or mitigate the effects of mental illness. Now, what are those effects? They reduce ultimately to two things. First, subjective distress. The patient is suffering. They feel terrible, anxious, depressed, tormented, unable to sleep, unable to think, unable to feel anything at all. That is the most immediate and most visible target. Second, deterioration of function. The patient's ability to work, to maintain relationships, to take care of themselves, to participate in life is eroding. Sometimes rapidly, sometimes glacially, but eroding nonetheless. And there is a third target that is often overlooked: distress in others, the family, the partner, the children, the co-workers. Mental illness does not confine itself politely to one skull. It radiates outward and damages everyone in its orbit. Now, your efforts to address these problems must operate on two timescales simultaneously. If the suffering is acute, if the patient is in crisis, if they are suicidal, if they are psychotic, if they cannot function at all, then short-term relief becomes the most important goal. You stabilize, you contain, you reduce the immediate danger. But once that fire is out, your horizon must shift to something much larger: long-term evolutionary advantage. And I use that phrase deliberately, because when you strip away all the clinical jargon, what you are really doing for your patients is improving their chances of success at the two things every living organism on this planet is trying to do. 1. Survive, stay alive, stay healthy, make decisions that do not lead to premature death or unnecessary suffering. And 2, and this is the part that nobody talks about in medical school, pass on their genetic material to the next generation. That is the closest any living being comes to immortality. It is the deepest biological imperative we have, and it means, in practical terms, helping your patient find a suitable partner, raise a family, maintain stable relationships, and be useful to the rest of society. That is not a sentimental aspiration. That is the evolutionary endgame. Everything else is commentary. So, how do we get there? Treatment, understood properly, is a set of countermeasures to illness. And those countermeasures span 5 domains. Not 1, not 2, 5. First, medication, fixing the biochemical disturbances that give rise to symptoms. This is what most people think psychiatry is. It is important, it is not sufficient, it is 1/5 of the picture. Second, psychotherapy, correcting faulty patterns of making sense out of reality, reacting to it emotionally, cognitively, and behaviorally. The patient who catastrophizes every setback, the patient who avoids every source of anxiety until their world shrinks to the size of a bedroom, the patient who cannot distinguish between a thought and a fact. These are patterns that medication alone will never touch. Third, biological health of the brain. The brain is the source of the mind. It is a physical organ. It needs blood flow, oxygen, neurotrophic factors, structural maintenance. And the single most reliable way to provide all of those things is physical exercise. Regular, sustained, aerobic exercise. This is not wellness fluff. The evidence base for exercise in depression, anxiety, and cognitive function is as strong as the evidence for most medications. Stronger in some cases. Fourth, preventing poisoning. The brain is exquisitely sensitive to chemical disruption. Alcohol, cannabis, stimulants, opioids, Benzodiazepines used recreationally. These are not neutral substances. They are disruptors. And you must ensure that the brain's natural homeostatic forces remain strong by normalizing sleep. Sleep is not a luxury. Sleep is when the brain repairs itself, consolidates memory, clears metabolic waste, recalibrates emotional circuitry. A patient who is not sleeping is a patient who cannot get better no matter what else you do. And beyond sleep, the patient needs structure with purpose in their day, not just activity. Purpose, a reason to get out of bed that connects them to something larger than their own suffering. Fifth and finally, social engineering, and I use that term deliberately. The patient must have the skills to select from the enormous variety of possible social interactions available to them, those which are beneficial. That means friendly, supportive, and offering a good model for how to survive and thrive. And equally important, the skills to identify and distance themselves from interactions that are toxic, exploitative, or destabilizing. This is not taught in any pharmacology course. It is one of the most important determinants of long-term outcome. 5 domains: medication, psychotherapy, brain health, prevention of poisoning and normalization of sleep, social selection. Miss any one of them and you are working with an incomplete toolkit. Now, during this process, and it is a process, not a single intervention, your patient is going to face all sorts of challenges, riddles, conundrums, problems that do not have obvious solutions, situations where every option seems bad. And you must be there for them, not to solve every problem yourself, but to give them a framework for successfully managing life's bottlenecks. And that framework borrows something from a world you might not expect: business. In order to systematize a complex problem, there is a tool called the Ishikawa diagram, named after Kaoru Ishikawa, a Japanese organizational theorist and professor at the University of Tokyo who developed it in the 1960s as part of quality management processes at Kawasaki shipyards. Of course, other names have been pinned onto this diagram that are now more popular than the original: the Fishbone diagram or the cause and effect diagram. Here is how it works. You draw a head on the right side, a triangle or a circle containing the problem, the challenge, the thing that needs to be resolved. Going to the left, you draw a long horizontal line, the backbone. And from this backbone, you draw arrows angling upward and downward, the ribs, each one leading to a category of causes. In manufacturing, the classic categories are materials, methods, machines, manpower, measurement, and environment. In clinical practice, you adapt them: biology, psychology, social circumstances, substances, sleep, function, relationships. But here is the critical point. This is a preliminary step. You have not resolved anything yet. You have merely defined the problem and organized its causes. You have taken chaos and given it structure. That alone has enormous value, because a problem you can see clearly is a problem you can begin to solve. Now the real work begins, and for that you use brainstorming. This technique was formalized by Alex Osborne, an advertising executive, in his 1953 book Applied Imagination. The core principle is simple: generate as many ideas as possible without judging any of them. Quantity over quality in the first phase. No idea is too absurd. No suggestion is dismissed. You are deliberately suspending your critical faculty to allow creative and lateral thinking to emerge. And you do this most of the time with the patient, not for the patient, with them, because the patient who participates in generating solutions is the patient who will actually implement them. Once you have generated a wide range of options, and it should be wide, wider than feels comfortable, you begin eliminating, one by one, based on 2 criteria: how realistic is this option, and how feasible is it for this particular patient, with their particular resources, limitations, and circumstances. Some options will be theoretically excellent, but practically impossible. Some will be easy to implement, but unlikely to make a meaningful difference. You are looking for the intersection of impactful and achievable. When you have narrowed the field to 2 or 3 reasonable options, you and the patient decide what to try first, particularly if the options are mutually exclusive. This decision should be collaborative. The patient's preferences, values, and willingness matter as much as your clinical judgment. A perfect plan that the patient will not follow is worse than a good plan that they will. Now you need a way to track implementation. And here another business tool is remarkably useful: the Kanban board. Kanban is a Japanese word meaning visual signal or card. It was developed in the late 1940s by Taiichi Ono at Toyota as part of the just-in-time manufacturing system. The idea was elegantly simple: visualize the flow of work so that bottlenecks become immediately apparent. A Kanban board, and this can be entirely in your mind, it does not need to be a physical object, divides all the tasks needed for an outcome into 3 columns: to do, in process, and resolved. A task typically moves from left to right, from the to-do list to the done list, but tasks can also move the other way. A task you thought was resolved may need revisiting. A task in process may reveal new subtasks that go back into the to-do column. The board is alive, it is dynamic, it reflects reality, not aspiration. Finally, you need metrics, ways to measure whether what you are doing is actually working. And these metrics are both temporal: how long has this been going on? When should we expect to see change? What is our deadline for reassessment? And qualitative: is the patient feeling better, functioning better, sleeping better, engaging with life more fully? In principle, the outcome metrics must be tailored for each task, for each patient. There is no universal recipe. A metric that matters for one patient, returning to work, for example, may be irrelevant for another whose primary goal is to stop having panic attacks in the supermarket. You must define success before you can measure it. Now, I should tell you something important. Most of the time, you will have to run this entire process in your mind, silently, because the patient may not recognize a problem that you have identified as a problem, or they may not be ready to accept it, or the problem may be so intertwined with their identity that naming it feels like an attack. You must be able to hold this framework internally, apply it invisibly, and guide the patient towards solutions without them necessarily seeing the scaffolding. All of this, the Ishikawa diagram, brainstorming, Kanban, metrics, none of this is new to healthcare. There was a time over a decade ago when some clinician managers insisted on imposing these systems onto psychiatry. It never caught on. Not because the systems were flawed, but because they were presented as documentation requirements, another layer of paperwork on top of an already impossibly cluttered mountain of demands. Clinicians saw them as bureaucratic impositions, not thinking tools, and they were right to resist that framing. But the underlying logic retains its value, enormous value, as a way of approaching any problem. It just needs to live in your head, not on a form. Now, you might be listening to all of this and thinking this sounds very rational, very logical, very businesslike. And in business, emotions are considered a hindrance, something to be excluded, controlled, minimized. So, do emotions play a role in real-life problem solving? I would say they play the central role. In fact, they are the fuel that feeds the entire machine. Without emotions, nothing will get done. Nothing in any domain of life, because emotions generate drive, motivation, the impulse to act. Behind every action any human being takes, there is an emotion. No matter how rational the action appears, no matter how analytical the context. Consider stockbrokers. What makes them execute trades all day, every day, under enormous pressure? You might say greed. And greed, the wish to amass resources, is really the desire for recognition, admiration, respect, status. And what is behind that? Something as simple as pleasure and happiness, which nobody would deny are emotions. The same is true for your patients. The patient who finally decides to leave an abusive relationship is not making a purely rational decision. They are driven by pain, by anger, by hope, by the desire for something better. The patient who starts exercising is not motivated by a meta-analysis. They are motivated by wanting to feel alive again. Emotion is the engine. Reason is the steering wheel. And this brings us to the final and most important point. In order to navigate this entire structure, from identifying the problem to organizing its causes to generating solutions to implementing them to measuring outcomes, you must be guided by reason and logic. Any other basis, intuition alone, ideology, wishful thinking, fear, tradition for its own sake, would be like trying to build a castle on quicksand. Sooner or later it will collapse, and it will never achieve the intended goals. Reason and logic are not cold, they are not heartless. They are the most compassionate tools you have, because a decision made with clear thinking is a decision that actually helps the patient. A decision made with muddled thinking, no matter how well-intentioned, is a decision that risks harm. And that brings us full circle. Primum non nocere. First, do no harm. Think clearly. Act deliberately. Use every tool available to you, and never forget that behind every clinical decision, there is a human being who is trusting you with something irreplaceable, their one life. That is the model. Use it well.